Thank you, Mr. Chairman, and thank all of you for being here. This is a very important program, certainly very important in my state, in the state of Georgia. SCHIP is the Peach Care program. We're very proud of it. It's been a very good program that has benefited many, many recipients. I want to ask you, I'll start with you, Ms. Snyder, and then Mr. Holmes, I also want you to address this. But I know that in my district alone, we've got 6 federally funded health centers, and they serve over 55,000 patients. They're very, very important. One of the things that we require, the federal statute requires, is that states reimburse these federally qualified health centers and rural health centers using prospective payment system. And there have been groups who've said this could be done better. Let me quote real quick. The National Association of Medicaid Directors, has said, this distinct reimbursement system limits Medicaid's ability to use the full range of value-based purchasing strategies in this care delivery setting, including models that incorporate financial risk. It also prevents many states from comprehensively transforming the health care system across all providers. The directors have said states need to be allowed to align value-based purchasing approaches. How do you feel about that? Ms. Snyder, what do you think?
Congressman Carter, I'm happy to answer the question to the degree that I can. What I can tell you is that the state in Texas is well aware of the requirement around the prospective payment system and very committed to working with all of our managed care and provider partners in the advancement of value-based purchasing initiatives. Unfortunately, I cannot answer specific questions in regard to FQHC reimbursement at this time because the state is in the midst of active litigation on the matter.
Oh, do tell. How about that?
I wish I could, but I can't.
Okay, we'll give you a pass. Mr. Holmes?
Over the years, payment methodologies have changed across all provider types, whether it's been a cost-based payment, whether it's a discounted fee-for-service payment, or whether it's a prospective payment system payment. FQHCs are currently reimbursed under an FQHC prospective payment methodology for both Medicare and Medicaid. A couple of years ago, Medicare updated their payment methodology, and I think it's important to note that Medicare in that payment methodology update retained the payment per visit methodology, where a bundled set of services is reimbursed under that methodology. We're looking at a change to value-based purchasing for all provider types. I think the question that comes in with value-based purchasing is how do you determine value? We have seen in Minnesota, for instance, we have clinical outcome disclosures for outcomes of care for all medical groups. And the medical groups will range from Mayo Clinic down to the smallest safety net provider. And there are different ratings for optimum care and for diabetic care or optimum cardiovascular care. But what concerns me about value-based payments is whether or not that value truly reflects the skill and the care of the provider, or if it reflects the patient population that provider served. If I was going to a value-based system, I would wonder whether or not the best value is perceived in the suburban areas where there's high levels of income, there's high levels of poverty, or low levels of poverty and high education. I think we have to be careful that value does not reflect our patient populations, but more accurately reflects the care that's delivered by the provider.
Okay. All right. Very quickly, I have just a few more seconds left, but I want to ask you, Mr. Holmes, if you've experienced the 340B program, do y'all use that at all, and what's been the impact on your systems there?
We use the 340B program. We have some savings under 340B. In turn, we use those savings to pay for some of our care coordinators and some of our patient assisters, where we can align our patients into the pharmaceutical manufacturers' patient assistance programs, because free is better than discounted.
Okay. Ms. Snyder, y'all use 340B?
We do.
And the impact?
I think it's a very valuable tool in terms of influencing reimbursement in regard to pharmaceuticals.
Okay. And what do you use the savings for? Can you identify it specifically?
I would be unable to identify it specifically, but certainly, I mean, I think we're always looking at opportunities to maximize savings that we're seeing in our system through various means, including.
Well, we're looking at that closely on this committee and on the O&I committee, so be prepared on that, okay?
Absolutely.
All right. Thank you, Mr. Chairman. I yield back.
Gentleman's time's expired, Chair. Thanks, the gentleman.